The topic given to me is diplopia evaluation. In about 20 minutes, I will try to give as much information as possible. This is how the talk will be. Initially, I'll be talking about applied anatomy. I think without anatomy, I don't think you'll be able to localize the lesions, followed by brief historical and examination tips. Then we'll go to individual cases. I have about 10 cases. We'll try to localize. I invite residents to contribute during the case discussions. This is the basic anatomy. I think just to quickly revise, you have 6 muscles for each eye. You have the recti, medial rectus, lateral rectus, superior and inferior recti, and 2 obliques, superior and inferior oblique. They give out 9 cardinal positions. You have to examine each eye in the 9 directions. These are called ductions. I don't think I should go into the details. You know these muscles which are required. The point to note is that the axis of rotation of the globe for the rectus and oblique muscles is exactly at 90 degrees. So one rectus and the other oblique, they work together just like the oxen tied by a yoke. That is why they are called yoked muscles. For example, for horizontal movements, one medial rectus and the opposite lateral rectus, they are the yoked muscles. And superior rectus on one side and inferior oblique on the other side are the yoked muscles. Inferior rectus on one side and superior oblique on the other side are the yoked muscles. They lead to these kind of 9 cardinal movements. This is the central position. This is the easiest to interpret. Looking to the right, right lateral rectus and left medial rectus. Looking to the left, left lateral rectus and right medial rectus. Looking up, both superior rectus and inferior oblique of both eyes are required. Looking right and up, right superior rectus and left inferior oblique. Down is inferior rectus and superior oblique, and correspondingly on the other side. This gets a little complicated as you go to the control of the eye movements. I think Dr. Madhusudan will be talking about the supracortical. So let us move from the globe to the brainstem nuclei. Any disease in the orbit can cause diplopia. Neuromuscular junction disorder can cause that. Then the 6th nerve, fascicle lesion can cause diplopia. 5th nerve nucleus is different because it has 2 components. One that supplies the lateral rectus of the ipsilateral eye. Then the other component innervates the medial rectus of the opposite side through the MLF, and that is why it produces the opposite medial rectus. So stimulation of the 6th nerve nucleus leads to ipsilateral eye abduction and contralateral eye adduction. That is the yoked muscles. So if there is a lesion here, you always get gaze palsy and not the abducens weakness. Same thing happens with PPRF, which has the excitatory burst neurons for the horizontal gaze. So in both these cases, you will get gaze palsy. And of course, with MLF lesions, you know that there is INO. And when these structures are too close to each other, you can get one and off syndrome. Coming to the 3rd nerve nucleus, in contrast to the 6th nerve nucleus, it is very complex. There are multiple subgroups of nuclei. In the center, there is an unpaired nucleus for lid elevation, levator palpebrae superioris. So that is why any nuclear lesion will cause bilateral ptosis. So if patient has a unilateral ptosis, you know that it is not a central lesion. Same way you have superior rectus and inferior rectus subgroup nuclei. Here for horizontal movement, what is important is the medial rectus that innervates the ipsilateral medial rectus. So you can have a 3rd nerve lesion causing medial rectus weakness. You also have horizontal semicircular canal connected to the 6th nerve nucleus. So during the head movements, the opposite 6th nerve is stimulated, and that is why you get an eye deviation to the right side. For the vertical movements, almost the similar mechanism, except that you have 4th nerve here. Previously, you have seen for horizontal eye movements, 3rd and 6th are important. For vertical, it is 3rd and 4th. Otherwise, the mechanism is almost similar. What is important to note is that here you get a skew deviation because you have otolith and vestibular organs. They are connected by graviceptive fibers through the MLF to the opposite side, INC and RMLF. That is why you get a skew deviation. So few anatomical tips before we go to the localization. For 3rd nerve palsy, as I already mentioned, you will get bilateral ptosis with a central brainstem lesion. And if one side superior rectus nucleus is involved, you will get the contralateral weakness because the innervation is by crossing fibers to the opposite side. Pupils can be involved because the pupillary fibers cross in the dorsal region of the midbrain. So that is why you can get pupillary involvement on one or both sides. Fascicular lesions typically have contralateral long tract deficits, including hemiparesis, ataxia, or tremor, depending on the structure which is involved. And if you have a divisional palsy, you suspect orbital disease. For example, superior division of third nerve supplies the superior rectus and levator papillaris superioris. So if the isolated superior rectus and LPS weakness is there, you know it is possibly an orbital disease. Same way, if inferior division is involved, you will get inferior rectus, medial rectus, inferior oblique plus pupillary involvement. Pupillary fibers go through the inferior division of the trigeminal of the third nerve. Isolated adduction deficit, if you find, you suspect a MLF lesion. I will show you the images there. Another important and confusing part is pupil. The classical teaching is that in compressive third nerve palsy, pupil is involved. In non-compressive lesion, pupil is spared. But these rules have exceptions. For example, pupil may not be involved in the early stages of a compressive lesion. So when the patient has a partial third nerve palsy, it can still be spared. In contrast, if there is a severe ischemic lesion of the optic nerve, though it is not a compressive lesion, pupil can be involved. So these rules are not absolute. So how to understand this rule is that if the patient has a complete third nerve palsy, pupil is still not involved, it is likely to be non-compressive. If patient has partial third nerve palsy, pupil is already involved, it is likely to be a compressive lesion. Fourth nerve palsy, it is again, it is a crossed nerve supply to the opposite superior oblique muscle. So you will get a contralateral palsy. You can have ipsilateral INO because MLF is very close to that, and also Horner syndrome can be there. Sixth nerve palsy, you can have nuclear and fascicular lesions. As I already mentioned, if there is a nuclear lesion, you will get horizontal gaze palsy, not the abducens weakness, and you can get MLF syndrome. Fascicular lesions, you can get involvement of the pyramidal tract, so you can get hemiparesis, lemniscus involvement causing hemisensory loss, and so on. Other long tract deficits can be there. And seventh nerve is involved because it loops around the sixth nerve nucleus, it can be paralyzed. This anatomy is important. This is the clivus seen from the superior view. As you can see, both abducens nerves are very close to each other at this location. That means a single lesion in the clivus, like a tumor, can cause bilateral sixth nerve paralysis without causing raised ICP. Normally we say bilateral sixth due to raised ICP. Here you need not have raised ICP, but still it can cause bilateral sixth nerve palsy. And it enters an important structure called Dorello's canal. The abducens nerve enters a Dorello's canal and then exits and then reaches the petrous apex. That is where Gradinogo syndrome is produced. Here you can see the petroclinoid ligament. It looks like a seat belt causing immobile sixth nerve. So when there is a head injury, this immobile nerve gets trapped and causes sixth nerve palsy. Now we have seen individual third, fourth, sixth nerve palsy. When they are grouped together and are involved commonly, then four possibilities are there. One is a CSF-based process like meningitis in the subarachnoid region, or cavernous sinus location that can cause third, fourth, sixth, V1, V2 paralysis in various combinations. When there is a polyneuritis cranialis, picking up individual cranial nerves, you can get that. Or neuromuscular junction disorder, which can mimic any eye movement disorder that we know. So these are the basics of anatomy that we must remember when you're interpreting this. The aim of history and examination is to localize the disease to one of these locations: orbital, muscle, NMJ, individual nerve palsies, nuclear lesions, internuclear lesions, cortical lesions, etc. Here I must say that the clinical examination is not 100% reliable, though we discuss a lot about this anatomy, things like that. There are studies which have shown that at best it is correct in 70% cases, 30% cases, especially the more complex diseases. If it is isolated sixth nerve, it is okay, but little more complicated, the accuracy comes down. So this is, history and examination is just a rough guide, which we should not forget. History, of course, a detailed history is important, but these 6 questions are aimed at localizing the lesion. This is from Continuum 2014. So, first question is monoocular versus binocular. If diplopia is horizontal, vertical, or torsional, is it worse on near gaze or far gaze? In which direction it gets worse? Is there any history of congenital strabismus? Are there any associated neurological symptoms and signs? With these questions, we can localize it a little better. Same way, when you're coming to examination, there are so many tests, but we can group them into 3 categories of tests. If you follow the sequence of events when you develop a diplopia, you can group them correctly. The first step, what happens is when there is a misalignment of the eyes, some tests are directed at proving that there is a misalignment. This leads to true and false images. So there are tests to show that there are true and false images. And there are compensatory mechanisms like head tilts, etc. So there are tests to prove that. So to show misalignment, you can just do a straightforward examination, observe for strabismus. You can check the individual eye movements and torsions, and also Hirschberg test. So I will discuss a little bit about Hirschberg test. Then to show the consequence, that is two images, you have diplopia charting. You can do that whether with colored glasses or Maddox rod test. And the compensatory mechanism you can show by head tilt, cover uncover test, and Beil-Shusky 3-step test. Let us look at this. Hirschberg test is shining a narrow beam of light and looking at the reflection of the light on the pupils. You can see that on the left side, it is in the center, almost in the center, but on the right side, it is on the margin of the cornea. That shows that the eye is deviated. One eye is deviated, one is not deviated. This is an obvious case of deviation, but in more subtle cases, this becomes really useful. Diplopia charting can be done with the help of colored glasses. Conventionally, the right eye has a red glass and green is for the left eye. That is the convention. This is reliable in the acute stages. As the time passes, the diplopia gets suppressed and this becomes less and less useful. Okay, patient looks at a light source at least a meter away, and he is supposed to mark the position of the colored objects, colored images in the visual field. There are certain rules to interpret the diplopia charting. If the misalignment varies with the direction of gaze, it is non-committant. This we know that there is a misalignment of the eyes and it keeps changing the direction. It is a neurological. If it remains constant, it is called committant. It is most likely a congenital squint. Based on the images, I will be showing a diplopia chart and we'll interpret that. These are the rules to remember. The false image is always displaced in the direction of the parotic muscle, and the outermost image is the false image. And the degree of separation of images increases in the direction of the parotic muscle. These are the basic rules which you should know. For example, let us look at this chart. There is a diplopia on looking to the right side. And the green is for the left and red is for the right. So diplopia is on this direction. The outer one is the false image always. So the false image is coming from the left eye. So the left eye, when you're looking to the right, which muscle is acting? It is the medial rectus. So we know that the left medial rectus is the one. Same patient, suppose diplopia increases on this leftward direction, which is the false image. Residents, the green one. The outermost one is the false image, the green one. Green is coming from the left eye. So which movement is required to move the left eye in the leftward direction? It is the abduction. So you know that it is the lateral rectus. The same way you can work out each one by looking at the outermost image, the color of the image, and the direction in which it is becoming worse. This is another test called cover-uncover test. Normally, when there is a subtle divergence between the two eyes, what happens? There is something called fusional reflex. We tend to fuse the image by compensating to produce a single image. This cover and uncover test is to break that fusion by covering one eye, then so that the squint becomes obvious. This is an example. There is something called primary deviation. That is this one, and secondary deviation. Always the secondary deviation is more than the primary deviation because of the Herring's law. And then finally, the Beil-Shusky 3-step test. This is useful for evaluation of vertical diplopia. For example, in a patient, this is how it is done. A patient has right hypertrophia. That means the right eye is elevated and left eye is on the lower level. Both are possible. Either right eye is abnormal or the left eye is abnormal. So you work out the muscles which are required for that. Here it is inferior rectus or superior oblique, or left side inferior oblique or superior rectus. Next, ask the patient to look to each side, left and right. For example, in this patient, the diplopia increases in left gaze. Then you have inferior oblique or the other side superior rectus, which is the common muscle in both situations. It is superior oblique on the right side or superior rectus on the other side. Then tilt the head to each side. Depending on which direction the diplopia increases, you can work out which muscles are involved and see the muscle which is common for all the three tests. In this case, the superior oblique on right side is common to all the three steps. So we prove that it is right superior oblique palsy. So now we go to the individual cases. Before we go there, I'll try to explain a little bit about the monoocular diplopia. When a patient complains of diplopia, the first question to ask is it monoocular or binocular? If it is a monoocular, do the pinhole correction. With pinhole, if it is getting corrected, it has to be a problem in the media. If it is not getting corrected, the problem can be in the retina or the cortex. Both are possible. So it can be psychogenic, as Dr. Karthik mentioned, it can be psychogenic, but that is after excluding all the other causes. Ocular causes like dry eye, corneal disease, refractive error, lens problems, etc. can cause monocular diplopia that gets corrected. Neurological problems like superior oblique myokemia, which is a continuous involuntary movement of the eye, can cause nystagmus, can cause eyelid issues, can cause this. When it is binocular, it is more likely to be a neurological, so we'll work on this more. So, what is the problem in this patient? Left eye looks normal, right eye appears bulged out, the lid is retracted, correct? So, what do you think? We have to rule out orbital disease. When there is a bulging of the eye, retraction and restriction of the movements, we have to rule out a orbital disease. So we do imaging of the orbit. In this case, imaging of the orbit was normal. Sorry, I think we are running out of time. In this patient, the lesion was here, thick enhancement. This patient turned out to be sarcoidosis patient. Sarcoid can involve the Muller muscles and that can cause lid retraction, giving the appearance of a bulged out eye. How much time I have, sir? 30 seconds. Sorry. Let us go to this patient. Young lady, ptosis diplopia. On few minutes of gaze, the right eye also start drooping, left eye worsens. So what is the diagnosis? But it is wrong. It is actually patient had a tuberculosis, encasing the brainstem, third nerve palsy. That can cause fatigue. So all fatigable ptosis is not myasthenia. There is an interesting case called midbrain myasthenia. So don't get trapped by the fatigable ptosis. It can be anything. This patient has, for 15 years, he has only one problem, that is diplopia. You can see that the right eye is getting adducted and no ptosis, no other fatigue. RNS was negative, acetylcholine antibodies, MuSK antibodies are all negative. But only problem is this diplopia. After 15 years, this test was available. Agrin came positive. So it's just a ocular myasthenia restricted only to one muscle, nothing else. I think I have to skip this. Maybe I will show this. So this is another patient. You can see there is a skew deviation. The right eye is lower and left is higher. And when you put the patient supine, that gets corrected. This is what is seen in skew deviation compared to superior oblique palsy. In skew deviation, when you put the patient supine, it gets corrected. That is one clue. This patient had a cerebellar hematoma. That itself can cause skew deviation. It's called cerebellar skew deviation. I'm sorry that video is not working. You can see that the eye is actually down and out. Down and out is seen in third nerve palsies. But when you do a complete examination, this patient had a convergence nystagmus and upward gaze palsy. So you can see that. You can see even the right eye. You can see the convergence nystagmus. When you test the eye movements, he is able to adduct the eye. So it is not a third nerve palsy. Almost last slide. So this is what he had, multiple abscesses in the tectal region, posterior fossa surrounding the brainstem. E. coli abscess was there. So unfortunately, due to lack of time, I'm not able to complete this. So what I conclude is that history and examination do help in anatomical localization in simple cases, but in complex cases, they become unreliable. Excess reliance need not be placed. Neuroimaging threshold should be low in these cases. Thank you.